Hello everyone, Happy New Year and welcome back to Dragon Bytes. I'm Asim, one of the presenters for Dragon Bytes and one of the trainees here in Wales. It's a new year and I guess it's time to get started with revision again. Luckily, this year we kick off with one of our favourites, Dr Raj Krishnan, one of the renal consultants at the University Hospital of Wales. He's going to have a chat today with Stacey Harris, one of the other presenters for Dragon Bytes, all about renal osteodystrophy. Anyway, let's get started.
So, hi, Dr. Krishnan. My name's Dr. Stacey Harris, and I'm a paediatric trainee. And I'd really like to thank you very much for joining us again for one of our podcasts for Dragon Bite. I've heard that you have been hogging the limelight this week, and it's your third presentation, and you still have many more to come. So, thank you very much for taking the time. So, I wanted to talk about renal osteodystrophy today. Dr. Krishnan, what is renal osteodystrophy and why do you want to talk about it?
Thank you, Stacey and Asim, for giving me the opportunity. I have to say, the fact is, I would like to always think that I'm tech savvy and I'm data savvy, but I should say when it comes to the tech savviness, the podcast has actually taught me a few things. So hopefully, I'm still on the learning curve with regards to that. Now, I have to say why renal osteodystrophy, and I'll actually come into what renal osteodystrophy is a bit later. Now, many moons back, I also went through my membership exams, and there was these. I'm for sure. I mean, I'm still looking these up, and there are these charts which shows the PTH arrow goes up, the calcium goes down, the phosphate goes up, and then they'll actually put the vitamin D in the whole of the model, and it'll actually get absolutely messed up. Now, I have to say, before I took up nephrology and before I passed my membership, this was absolutely a muddy thing in my head. I didn't know, and I will actually mug it up for the exam, go for the exam, and I'll come out, step out, and I've forgotten it all. Or even worse, I would have gone for my exam and I would have messed it up completely. That's so it's actually a personal experience which actually made me think, oh, there is actually a better way of learning renal osteodystrophy. And I have to say, and if I can actually help people to achieve that the fact that we don't need those charts where the arrows go up, where the arrows go down, it will be brilliant. And I have to say, if you're actually going to come to work with me in the nephrology unit at UHW, that's something that I will actually do. Just make it very pure and simple. I'll take half a sheet of an A4 paper, size paper, and I'll actually explain it to you. So renal osteodystrophy, and what I am going to do is I will talk about few of these, what it actually means, and please feel free to stop me at any time, and then we'll actually go through what it means, how can actually we can draw it apart. Now, I have to say I appreciate this is a podcast, and there are limitations with regards to how much I can actually show, and how much I can actually move my hands and show my PowerPoint skills here. But what I would like to do as a part of this process, as while we are starting this process, is to take a sheet of paper and write down calcium times phosphate is equal to K, the constant. So the fact that your calcium times your phosphate product in your body is a constant. So whatever happens, so if you actually have your calcium goes up, your phosphate has to go down. If your phosphate goes up, your calcium has to go down. So I have to say, this is, I mean, I have to say, there's loads of things that's actually happening in the world of mineral bone metabolism. I'm not going to talk about any of the hi-fi stuff. I'm just going to put it to pure simple terms. So if you got calcium times phosphate equals K is your first step. Now, when you have your kidney, the good thing about your body is it likes a phosphate, but it actually dumps the phosphate. That's what it is. So you'll actually have quite a lot of dumping of the phosphate going down in the urine. So, but then what a kidney loves is also it loves the calcium. So it actually like to reabsorb the calcium quite back too. So it'll absorb some of the phosphate, but quite of the majority of the phosphate is quite a bit of it is actually being peed out too. So the kidney also has got another role, and this is quite important. And sometimes people tend to forget it. So, the 125 hydroxylation of vitamin D happens in the kidney too. So remember three things: calcium being reabsorbed, phosphate being chucked out of the kidney, and the vitamin D conversion. Now, just imagine your kidney is failed. So your kidney is actually failed. So just if I was trying to draw a picture of the kidney, draw the picture of the kidney, just put a cross across it. So what will actually happen? Your kidney can't dump your phosphate. The calcium will actually not be reabsorbed, so your calcium goes down. So your calcium is down, your phosphate is significantly high. And of course, that vitamin D conversion is definitely not actually happening either. So when your calcium is down, what actually happens is the body says, hang on, I don't like this. I can't see this going further. So it'll actually say, it'll tell your parathormone, the parathyroid gland, which is actually sitting behind your thyroid gland, saying, hang on, I need a bit more calcium in here. So the parathormone will swing into action and basically resorb the calcium from your bone to try to make sure that the calcium is actually being normalized here. So what you'll actually have is someone with a chronic kidney disease. You will actually have a low calcium, you will have a high phosphate, but you will have a very high PTH. And that PTH is basically, so the PTH relation between calcium and PTH is more or less like your TSH and the thyroxine. So you give too much thyroxine, your TSH is suppressed. You don't have thyroxine, your TSH is high. So that sort of a relationship, that sort of an inverse relationship is what calcium and the PTH does have. So that low calcium, it could be quite low, a high phosphate and a very high PTH is renal osteodystrophy or secondary hyperparathyroidism. And I should say that is the most simplest way of spelling it out. And I wanted to do is I will talk about this first before I go on to the next phenomenon. So what if you actually come and see a patient who's got renal failure? What will you find the renal physicians do? They'll put them on calcium carbonate, they'll put them on alpha calcidol, and they will put them on vitamin D supplements. So they will put them on calcium carbonate. Why they put them on calcium carbonate? And they will actually give specific instructions saying, take your calcium carbonate when you're having your food. So what it actually says is cut down when you're actually having the food, that calcium carbonate will combine with the dietary phosphate and you'll just put it out. The calcium you're giving is alpha calcidol. That'll actually help to elevate your total calcium in your body. And the vitamin D, of course, the vitamin D supplementation is not actually happening, and that will help to suppress the 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 PTH down because you don't want that high PTH. You'll always hear in the good old book saying that patients with chronic kidney disease will actually are more likely to be having fractures because the bone has been thin, bone has been resorbed. So this is what secondary osteodystrophy is. So the fact is you have a kidney failed, high phosphate, low calcium, and a very high PTH. Does that make it clear, Stacey?
Yeah, that does. I am frantically writing notes.
So that is what secondary osteodystrophy is. And whenever you are actually trying to learn about the secondary hyperparathyroidism or renal osteodystrophy, always, always start off as secondary hyperparathyroidism, renal osteodystrophy. The graph will say primary, secondary, tertiary. Please don't. Start off with secondary. And then once you have outlined secondary very clearly, you know why secondary is. So if you have a patient who came in with chronic kidney disease and you find a significantly raised this sort of a phenomenon where you have this very raised PTH, a low calcium, raised phosphate, you think, oh yeah, this is chronic kidney disease. This has been going on for the last few weeks. At the same time, if you have someone with acute kidney injury, you may not find it because it actually takes a couple of weeks, 2 to 3 weeks, for at least this to actually settle in. So it's always bearing in mind. So sometimes this is what the nephrologist will do is go and get your PTH done, and they are trying to find out. They're trying to suss out: is this primary? Is this an acute one? Is it a chronic one? So we got secondary hyperparathyroidism sorted or renal osteodystrophy sorted. So that's very clear. You know where the arrows are now going, and you know the reason why these arrows are actually going up and down. So if I was actually going to move this a bit more further down the line, let's talk about tertiary hyperparathyroidism. So the fact is, you need to have secondary to have tertiary hyperparathyroidism. And when you talk about tertiary hyperparathyroidism, what you will actually find is the patient who's been having chronic kidney disease for a long time, who is not taking their calcium carbonate, because trust me, it's vile. That's that medication is actually one of the most difficult. It's literally chalk you're actually trying to have with your food. So it's not a surprise that patients are actually non-compliant with that. So you have chronic kidney disease for a long period. You have secondary hyperparathyroidism running for a long period. What actually happens is you somehow control your phosphate. So your phosphate is more or less, normal, maybe slightly in the higher side. Calcium just about within the normal range, but your PTH is still high. Your PTH cannot be explained by that relationship you had, that inverse relationship you had between the calcium and the PTH is completely gone, because the parathormone has been secreting on an industrial basis for the last few weeks, and now it's become a bit autonomous. It starts producing everything on its own. So it'll actually do. So even if you try to control the calcium, the PTH is still high. So you're going to have that bone resorption. So if you take an X-ray of these patients, what you will actually find is they have the resorption of the bones. You'll actually have the thin phalanges. You'll actually have the end of the bones actually being completely gone, and you will find quite good going ricketry changes there. So what do you do then? So this is when traditionally people will say, oh, well, let's actually take the parathyroid gland out. So you would actually do parathyroidectomy for these patients when you actually can't control it. These days, it's not very often that we tend to do that, because there are other medications like calcium mimetics, which we have help to mimic the calcium, but doesn't give you the high calcium, which will help to suppress the PTH down. So when you are talking about tertiary hyperparathyroidism, is actually the fact that you have a very, very raised or a very raised PTH, a calcium which is lowish, normal, a phosphate which is also, can be on the higher side, but it shows a degree of non-compliance. But that 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 PTH gives it actually away. So that's tertiary hyperparathyroidism, and you cannot diagnose tertiary hyperparathyroidism unless you have the secondary hyperparathyroidism. Yeah. So so we've covered two things in the last 10 minutes. One is secondary hyperparathyroidism and and tertiary hyperparathyroidism. Does that sound okay to you, Stacey?
Yeah, that's great. So just to recap, so I got it clear in my head. So
Yep,
in secondary hyperparathyroidism, you get
yep,
a low calcium
yep,
and a high phosphate
yep.
and a high PTH.
PTH. So that the low calcium is stimulating that PTH for
Yeah.
you.
Okay. And the reason why you have a high phosphate is because the damaged kidneys aren't able to excrete it. Is that right?
Yeah, absolutely. The fact is, you are actually have got, you take a pint of milk, you've got enough and more phosphate in there. So the fact is, the medication that you use for the secondary hyperparathyroidism is actually a phosphate binder, oh, aka calcium carbonate. So the fact is, so people will actually tend to do it. The renal physicians again are extremely careful not to raise your calcium. So even if the primary importance, people will also say, get the phosphate on, and raise your raise your calcium. Because if you raise your calcium and your phosphate at the same time, your product is going to be very high. So if you iatrogenically do it, what you will find is calciphylaxis. You will actually find calcium deposits in your stone, in your skin, in your sclera, and worse and foremost, in your blood vessels. So the fact is, the arteries will not become compliant. They will become much more stiffer. And this child, if who has got chronic kidney disease, you're just cutting their life by a few number of years. So it's actually very important that you get the phosphate under control, you get the calcium up for the same reason, and that will actually help. And so that calcium, especially, will help to control that PTH down further down. Now, the tertiary hyperparathyroidism, you can actually do your whatever calcium and phosphate you do, it's not going to be controlled, because it's actually become a bit more autonomous here, because you've been actually been secreting in mega amounts for some time, and that's why you face
Mm.
it.
And so in tertiary hyperparathyroidism, um, you get a really high PTH, but then your phosphate is normal rather than high. Is that right?
Yeah,
Yeah.
I mean, I should say it all depends upon how well you've been controlled your phosphate on that particular occasion on the last few weeks.
Okay.
But what you are going to find is you cannot explain the PTH, and it's actually you basically think this doesn't actually add up. This amount of PTH rise. So then you think, oh gosh, okay, this has been going on for
Mm.
some time. There's a degree, and this is something that you'll actually find in patients who are actually on dialysis for a year or two, who's definitely may not been non-compliant with their medications.
Mm. So you mentioned that you give them phosphate binders, calcium
Carbonate.
calcium carbonate. Do you give them any other treatment at all?
No, there are different forms of phosphate binders, and I should say the tendency these days is to use a non-calcium based phosphate binder because you don't want to raise the calcium too high either. Uh, there are there are benefits for that too. But again, the first line will be to start off with a calcium carbonate or a calcium acetate. So the fact that you will actually take it along with your diet, and that's the most difficult bit these patients actually face because they then so you'll say, oh, you're going to have an extra piece of cheese, or you're actually having more snacks. Then make sure that you take that extra calcium carbonate with you, or the acetate with you, so that it actually gets pooed out so that the fact is it's not being so the calcium and the phosphate will form a complex which is difficult for the gut to reabsorb uh, uh, the phosphate element of it, and so you can control your phosphate much
Mm.
better.
Okay. So you're basically trying to dump phosphate rather than doing it with the kidneys, but
Yep,
doing it with the bowel instead.
absolutely.
Yeah. With
Absolutely.
the
I should say the fact, yeah, and I should say the fact is, even then, you could always ask the question, what's then dialysis actually doing? The dialysis will help to control the phosphate, but there is actually limitations. So how far the diet, the pho- the dialysis actually can do that. So the fact is, this is why you'll actually find the dietitians will come in and basically say, we need to actually have, control the amount of protein that you're actually having, and also to look into the amount of phosphate we are actually intaking at the moment. So it is it I mean, I should say, if you're actually looking for a single magic bullet to fix it, there is none. It's actually a combination of different therapies that you actually need to do that.
Okay. So yeah, so a dietitian would look at what they're actually eating and try and rather than just getting rid eating whatever you wanted to and getting rid of it with medication to try and actually reduce the amount that you're taking in at the same time. Yeah.
Yep.
Okay. And so what about vitamin D then? So because isn't it
Yeah.
that the
So
kidneys can't activate the vitamin D?
yeah, I mean, I should say the role of the metabolic bone disease spectrum is just really mushroomed out, and I don't think so. As a trainee who who are actually going for exams, you really need to know that. But as in the time to come by, you're going to hear about phosphotonins, fibroblast growth factor 23, FGF23s, and other stuff actually going to come really in there. So the fact is, what you're actually going to find is as time goes by, there are more and more factors going to come in. But when it comes to vitamin D, you need to replace it. And now, again, if you ask us, the nephrologist, will basically say, I want to have a level of more than 75. I know the recommendations can actually change, but most of the time we'll actually accept a vitamin D level of more than 50 nanograms per liter. But we would say, for if you got chronic kidney disease, and that actually varies according to your degree of chronic kidney disease. But on the whole, if you have someone who's dialysis dependent, we will say anything more than 75. So this will also help to control your PTH and also help with your calcium too. So these are things that you really need to look into when you're actually doing this.
And do you give them an activated form of vitamin D then because because the kidneys can't actually activate it?
Absolutely. I mean, I should say the more or less the alpha calcidol is actually has got a degree of that, and also will help to increase your ionized calcium much more significantly. So if you're actually in a neonatal unit stuck with hypocalcemia, alpha calcidol is actually a brilliant way of bringing the calcium up.
Okay. And so, how do you monitor this? Do you have to just do bloods regularly and try and come
Absolutely.
down?
Yeah, absolutely. Absolutely. And I think the fact is, the only way we don't do it with X-rays. We don't do it at all with X-rays. And I have to say, it should, if you have a chronic kidney disease patient and having some X-ray changes, it's not a surprise. But what we will like to do is we like to monitor with the PTH. Now, when you come to the PTH side of things, the normal PTH, they'll say is around 6 to 7. We will actually aim for a PTH which is 2 to 3 times normal. And so what we are trying to do is not to maintain a normal PTH. We are actually trying to aim for a PTH which is 2 to 3 times normal. So even when I'm saying I'm talking about a high PTH, so I'm talking about a PTH which is 50 or 60 or 70. So when I say 2 to 3 times, so if I get a PTH in the teens, in the 20s, I'm happily accepting it. And the reason by that is when you have chronic kidney disease, you have inactive forms of PTH. And if you actually measure that and you're going to act on that, what you'll actually do is you will actually suppress your PTH too low. And that's bad too, because you can give rise to adynamic bone disease, which can actually give rise to fractures. So you don't want the PTH too high, you don't want the PTH too low. You want it actually 2 to 3 times the normal. So that's what we will be aiming for the PTH levels to come back to. So if you've got someone with chronic kidney disease, if you will need to maintain it around that level rather than to maintain it tightly within the lower side. So the fact is, if I have a patient who's got a PTH as to uh, very well controlled, i.e., within the normal limits of lab values, I'll be saying, no, it's actually over control, over suppressed. We need to relax a bit more further, and we need to get that PTH further up. So that's quite important that we actually remember that.
Yeah, that is an interesting point, isn't it? Because yeah, you probably wouldn't really think about that if you weren't used to seeing patients with chronic kidney disease. Mm,
Yeah.
interesting. So, is there anything that can cure this uh, renal osteodystrophy?
No, I mean, I should say, apart from these medications, the only way forward is to have a transplant. And once you have a transplant, then you basically know where you are, what is actually adding up. And then you'll actually find everything goes the other way around. And in fact, you'll actually find a low phosphate in most of these patients because of the medication they are actually on, and there's a bit of phosphate dumping that's actually going on too. So then you're actually trying to catch up with the phosphate in these patients. But the real answer to that is to have a transplant, and you will actually see the biochemistry getting better. Most of the time, the PTH will actually come back, but if you have a degree of tertiary hyperparathyroidism, that may continue, and that needs to be monitored. And even if it is post-transplant, that's because that's the only way you can actually get on top of it altogether.
Yeah, that's what I was going to ask. So,
The-
if they, so it does, you still sometimes do get problems with them, uh,
yeah, yeah,
even afterwards, but a lot of the time it does improve somewhat.
yeah,
And does the
that's
bone
absolutely right.
changes improve, or do you?
Oh yes, yeah, yeah. No, the bone changes absolutely will actually improve, and the fact is, in a year later, you wouldn't be able to find any of these changes, and you'll actually find no cuppings, playing, or fraying. You'll actually find it everything they are just looking absolutely intact without any moth-eaten appearance, so of the long end of the bone. So that's actually quite interesting.
Wow, that
Uh,
isn't that really is interesting and amazing, isn't it? Hmm.
so the one thing that I haven't covered is actually primary
Yeah.
hyperparathyroidism. So the fact is, and I should say, it's for I deliberately left it out for the very last because to me it's got nothing to do with the kidneys. Primary hyperparathyroidism is you have an adenoma, let's say on a parathyroid gland. So what happens is, you let's say you have a malignancy, you have something that's actually stimulated the parathyroid gland, and the parathyroid gland starts secreting PTH. So then what actually happens is that you have high PTH, and then that will actually go and pull the calcium out of the bones, and you actually have a highish calcium too. And you could have a phosphate which is slightly normal or low normal, and that's what you'll find. So if you find someone with a raised calcium, the thing to do is to see what's your PTH actually doing. So if your PTH is also raised, then you're basically saying, okay, this is possibly coming from the parathyroid gland. But then, I will actually just, ask people to just go back a few years back. If we were doing adult medicine, if I found a patient with raised calcium, you will think malignancy there. And then that'll be useful to say, so what is your PTH actually then doing? And if your PTH is then suppressed, then it'll say, this is nothing to do with my parathyroid gland. This is actually some other tumor mass which is actually secreting the calcium there. So the fact is, when you talk about primary hyperparathyroidism, what you are actually going to find out is the starting process is actually with the parathyroid gland. You find a raised PTH, you find a really raised calcium, and you find a phosphate, which is on the lower side or could be on the lower normal side. And that will actually give you the picture. So the fact is, when I look at a calcium, I don't, whatever way I want to interpret it, I will actually be interpreting in a few ways. And my few ways is basically to see what's happening with my PTH, what's happening with my phosphate too. So that is what this primary hyperparathyroidism is. And what is the impact on the kidneys? Of course, it actually gives rise to kidney stones. So I don't know whether you remember the good old days when we were all house officers, when we did our OHCM. We all talk about groans, moans, and psychic moans. So groans, bones, and psychic moans, and that's what a hypercalcemia will actually give rise to. So it's important that you actually have a connection between your PTH and your phosphate too, when you actually really see, especially when you see a higher calcium, and that's primary hyperparathyroidism in a few words.
Yeah, amazing. That was lovely to have a bit of a refresher. Yeah, around 25 minutes of
Yeah. The
hyperparathyroidism. That's amazing. It's really great. I'm sure that lots of people will really appreciate.
the 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 only thing that I should say, all of what I have actually spoken is actually condensed my experience over the last 20 years in nephrology. And I should say, the fact is, this is what I find is useful, so that you call me up in 2 in the morning, I can still be able to answer it rather than thinking whether the arrow goes up and down. So the one thing that I'll actually tell people is, if you do see a low calcium, do check your magnesium, and you'll always find that calcium is related to your magnesium. And the reason is the fact that if your magnesium is below 0.45, what actually happens is it suppresses your PTH again, and that's why you get a calcium, so a lower calcium. So when you see a lower calcium, I know this is a bit beyond the point, but I'm just staying with the calcium phenomenon side and just bringing the relationship with the calcium magnesium. Just check what is your magnesium. Magnesium is on the lower side. That indirectly is telling you your PTH is actually suppressed. And that will actually be another way to actually then you say, okay, I need to give them person calcium, and also need to think in terms of a magnesium correction too.
Mm.
There you go. I'll stop there.
Yeah, thank you. I think this is really great to be able to just have a really quick podcast that you can listen to this and refresh yourself, on a car journey or something like that. So I really appreciate you joining us again, Dr. Krishnan.
Thank you, Stacey.
Thank you.
Bye bye.
And I just wanted to say thank you to Raj and Stacey for recording that for us. I learned a lot about how PTH, calcium, and phosphate all interact with each other. If you've got exams coming up, please head to our website where we've got lots of previous episodes about different medical conditions recorded. We've got more coming for you next week. Thank you for listening to Dragon Bytes.